I'm Thomas Baldrick here at ASH 2014. The handsome man to my right is Dr. Jesus Berdeja. He's from the Sarah Cannon Research Institute in Nashville. Thanks for stopping by, sir.
Thank you.
Tell us about this phase 1 study that you're presenting here.
So it's actually a very simple study. It's a phase 1 study of pharmacokinetics of Elotuzumab, Lenalidomide, Dexamethasone in patients with various degrees of renal insufficiency and multiple myeloma. So multiple myeloma, as we all know, is the second most common blood disorder, blood cancer, and it affects many different organ systems. And one of the systems that it affects the most is the kidneys. So about a third of patients that present with myeloma present with renal insufficiency. Sometimes they come on dialysis. So when drugs are developed in this disease, these patients are excluded from clinical trials. So when the clinician is trying to treat patients that actually have kidney disease with their myeloma, it's hard to know what to do with the doses. And so the purpose of this trial was to look at this new antibody called Elotuzumab, which is a monoclonal antibody that is targeted against SLAMF7 or CS1, which is a glycoprotein that sits on the myeloma cells. It's only expressed in myeloma cells and NK cells, no other cells. This antibody binds and is actually really benefited by adding this drug called lenalidomide to it. Lenalidomide causes immune modulation that really helps the immune system kill the cells via the antibody. That's one postulate of how that works. So this drug looks like it's going to be given in combination with lenalidomide. Well, lenalidomide is a drug that's used in myeloma quite often, and it has very specific dose reductions depending on the patient's kidney dysfunction. So the goal of the study was to see if we can give the combination of elotuzumab, lenalidomide, dexamethasone, and look at the pharmacokinetics and see if elotuzumab needs to be dose adjusted.
What were some of the highlights of your data?
So what we saw was that we took patients with normal kidneys, patients with very bad kidneys, creatinine clearance is less than 30 but not on dialysis, which are often excluded from clinical trials, and patients on dialysis. And all patients were treated with lenalidomide, dexamethasone. The lenalidomide was adjusted, like I said before. The elotuzumab was not. It was given IV, 10 milligrams per kilogram, one-time dose first cycle, and then weekly for the next two cycles, and then every other week for the cycles after that. And what we saw was that the pharmacokinetics of the drug were identical in all three groups. There was no modulation whatsoever of the half-life of the drug, the Cmax of the drug, the concentration of the drugs were all identical, which implies that you do not have to adjust the dose of elotuzumab. In terms of response rates, these were small numbers in all three, but all patients in all groups responded as we would expect. And even though there was a decreased response in the patients on dialysis, that is actually a well-known fact that these patients don't respond as well. But we can't say much about response rates just because of the small numbers. So we were able to basically show the effect that we wanted was that elotuzumab does not require kidney function to be given appropriately, and there's no excess toxicity.
So what are next steps?
So the next steps are, this combination is being tested in phase 3 trials in both the relapse setting and also the frontline setting. Most of us believe that probably in the next year or two this drug will be FDA approved. And so I'm hoping that this trial will show the clinician, once the drug is out there for them, that they can give this safely to their patients regardless of their renal function.
Very good. Thank you, doctor. I wish you the best of luck.
Thank you.
Appreciate your time.